or the carpal bone, or yeah, carpal bone. So okay, so let's talk about the pelvis for a minute, because this will be kind of my chance to give you kind of a heads up for next week when you go into the lab. Okay, so we call this we call one section of this an os coxa. Yeah, let me write that down. I don't know if I have it. All right, it's an os. It's called an OS, separate word, C-O-X-A, os coxa. Is what we call one section of this, and then totally it's a hip. And so let's go through some of the parts. Now, in reality, this in an adult, this looks like this, like one big fused bone. But in fetally and up to puberty, these are three bones that are then become fused together. So we have the ilium, the ischium, and the pubis. And this part of the bone here, this is called the acetabulum, and that means vinegar bowl, and that's the socket. That's your hip socket. So the femur, the head of the femur, is anchored extremely tightly right here into the acetabulum. Just as in the shoulder girdle, there is a labrum, a cartilage labrum, that reaches out over the big round head of the femur, and then and there was a series of ligaments that wrap around that. And so when we walk, have you guys ever twisted a towel? You know how stiff it gets? So when we walk, those ligaments twist, and we actually end up with greater stability in our hip because of the twisting of those ligaments as we take a long step. So to me, one of the what I love about the lower limb is this ability that we have to be bipedal, that we are habitually walk upright. I mean, this is, no other animals share this with us. I mean, there are bonobos, is a type of chimpanzee that is found in Africa, and they do walk upright. They mate face to face, but they don't habitually walk upright. So you can see, I have some pictures in a book I have that shows them walking, and they're carrying an infant, but it's not like they do that habitually. We habitually walk upright. I mean, if we tried to walk on all fours, it would really cause a lot of problems. So this is the big thing about walking upright. So we have, not only does, I wish I brought a lower limb. I don't know how far we get, but maybe I can maybe explain it to you. Okay, so, wait, let me see if I have it. Let's keep going. And when we get to the foot, the reason, one of the key elements that allows us to walk upright is our foot. This whole geometry of our lower limb, starting with our feet and our toes, traveling up all the way up into our hip, and the muscle configuration that we have, the way the joints work together, this locking mechanism that we have, really makes a big difference. And so I'll kind of try to give it to you as we're walking through. So let's talk about some of these other landmarks. So we have the sacroiliac joint, which was, you got that from the first lab. This is called the ilium, so this is the crest of the ilium. This is obviously the obturator foramen. This is the pubis bone right here. This is the pubic symphysis. So now we've talked about this. When we go into arthrology, I'll say this again, but we have a series of symphysis joints. They're fibrocartilage joints. They're somewhat they're movable, not highly movable, but movable, and they're all located in the midline of the body. So we have two symphysis joints on either side where the clavicle is attached. We have the pubic symphysis, and then all the vertebrae are symphysis. So this is kind of interesting. Then we have these symphyses all down the center of the body, these fibrous cartilaginous joints that are very strong and sturdy. Let me see what else can I show you. The ilium, we have the ischial tuberosity. You're sitting on your ischial tuberosity right now, most of you, unless you're slouching. But if you're sitting upright, we have this little bony Anyone confused about a tuberosity? What that, so it's kind of this bony, what it sounds like, a bunch of little bony, rough area, and that's right here on the ischium. Now, ramus, we've had the word ramus before in the mandible. Well, we have two rami here. We have I think in your lab manual it's the superior and inferior ramus. We could also call this the iliopubic ramus and the ischiopubic ramus. So it's just the branch between those two bones. And in life, in living, the obturator foramen is filled with a membrane, like a connective tissue, but then we have the obturator nerve and some blood vessels and things like that that pass through there, so it's kind of interesting. Okay, so the ilium is this first of these three bones. It has the greater sciatic notch. Let me see if I can show you. This right here is the greater sciatic notch. I think I have a picture of the bone in isolation so you can see that, but this is the greater sciatic notch. So the sciatic nerve passes through that sciatic nerve notch. And the sciatic nerve, when you get to see it in a couple weeks, it's about the thickness of my finger. It is huge. You cannot believe how big this nerve is. And so when people complain about this hurting, it's a common sight of pain as we get older. You can see, and then it divides. So then we have the ischium and the pubis. These are the two other bones. The ischium, really it is the tuberosity is the most prominent, and the pubis are these superior and inferior rami. Okay, here we go. This is the picture I was looking for. Okay, so here you can see those three bones. Here's the acetabulum. And the easiest way to find these or to figure these bones is to think of the acetabulum being cut into thirds, like a pie that you just cut into thirds. And then you'll have this superior curve. The third would be the ilium, and the kind of posterior third would be the ischium, and the anterior third is the pubis. And then this bone collectively is called the os coxa. Mostly that's kind of, let's see, it's used a lot in forensic reports, just when you say the os coxa, because adults, the bones separate, the soft tissue is gone, and you have these bones. So anyway, here are some of the landmarks. Somebody beeped here. Anyway, so here's some of the landmarks. Now, so here, let me draw your attention to this one. The anterior superior iliac spine, and then we have the anterior inferior iliac spine. Now, if I had a hip bone and I showed you this point, you could probably come up with that name. I mean, it's right here. You can palpate your own. We can all palpate our the crest of the ilium, because there is it's just skin right there. You just can feel it right here. And no matter how big you are, you're going to have a little tuck right there, because there is you could have, everyone, if you have a lot of body fat, you still have a little tuck right there, which is because there is no tissue, there's just skin, there's no muscle or anything over that, right over this little crest right here. And so the anterior superior iliac spine, you can just almost palpate, because it's right. So here's the crest, and then right at the edge is this. This is the attachment site for our sartorius muscles. So the sartorius muscle is one of the longest muscles in our body, and it is this one that we use to cross our legs. One muscle does all those actions because it's very, very long. And it's the one that, if you look, you can see a little S shape to your thigh here, and that's the sartorius muscle. And sometimes, if people are very well developed, you can see it even more clearly. Here, and so, if we have the anterior, superior, anterior, inferior, what else do we have?
Posterior.
So yeah, here we have posterior, superior, and posterior, inferior. Now these 2 points are kind of locked into the sacrum. So there's really no muscle site attachment to those, but there is muscle site attachments to these 2, but not here. But because when you look at the bone in isolation, you can see these, and so the early anatomists so we have the greater sciatic notch. So if we have the greater sciatic notch, what else do we have? The lesser sciatic notch, and here it is right here. It's on the ischium. We have this little spine that's on the ischium. That's the ischial spine. Differentiate it from these two. Posterior superior, posterior inferior, greater sciatic notch, then ischial spine. Because this one is difficult. A lot of students get confused about that. And then here is the ischial tuberosity. Now inside the acetabulum, there are a couple of interesting landmarks. There is what we call the acetabular notch, which is found at the most inferior region of the acetabulum. There's a little notch in the bone. And then inside the bone, there is there's a little deeper fossa, right in the deepest part of the fossa. And then around it, there is a smooth, can you kind of see how that looks a little smoother, even though this is an artist's drawing? So, so this, you'll find those. And this site down, the deepest site that's kind of rough, is an attachment site for a ligament called the, I looked it up last year, I remember. It's called the ligament at the head of the femur, of all creative names. But that's what it's called, the ligament at the head of the femur. But in the femur, at the head of the femur, you'll see a little dent, which I'll show you in a minute, and that's called the fovea capita, and capitis. And then that is where the ligament occurs from the head of the femur, and it's locked into the acetabulum from the inside. And then we have this labrum and these ligaments on the outside that are formed in a spiral. Okay, so now, this is also very confusing about the pelvis. We have these terms. We have a lot of terms to describe the pelvis: pelvic brim, false pelvis, true pelvis, and let me show you what that is. So when we put the pelvis all together, you see we have this, what's called the arcuate line, and the pectineal line. It's actually, the arcuate line is here, the pectineal line is here, but we have this line that is formed by the bones. It's kind of a change of direction of the bone. And above this line, this is called the false pelvis, and below the line is called the true pelvis. And this line is the pelvic brim. When you take the whole thing together, it's called the pelvic brim. Now, my anthropologist self goes, wow, why do we have so many names for this same region? And, you know, because I'm thinking, wow, it must be important. Anytime humans put a lot of words on something, it's very important to their culture. So this is obviously very important to us because it's reproduction. And so here's just another picture of this. So here we have the false pelvis and the true pelvis. And this would be the pelvic brim. And then the axis is this angle that is formed between the two, this plane of the pelvic outlet. So we have the pelvic inlet and the pelvic outlet, for obvious reasons, before childbirth. So it comes in and then goes out. The baby actually has to do this twist to get around the coccyx, which is kind of interesting. So we see a lot of sexual dimorphism in the pelvis. And again, here's just another picture of the false and true pelvis. Now looking at this pelvis, you see how this is called the pubic angle, that angle, and it's very wide in females and very narrow in males. So that's an important thing to note. The wing, this is called the ala, just a general term. The parts of the ilium that flare out are called the ala. In females, we have a very wide, broad ala, and males, very narrow ala. The sciatic notch in females, very wide, and males, very narrow. So, for obvious reasons, and let me see if I have a picture, male and female, I don't. So, but we do have a lot of male and female pelvises in the lab. This will be a big part of what you look at next week. So when you look down through the center here, this pelvic inlet, for females it's very round, and for males it's almost heart-shaped, kind of narrow and heart-shaped. And in the skull, you know, we said that females kind of retain the juvenile characteristics. Males have this greater skull development from the testosterone. Well, the pelvis is the opposite. So males kind of retain more of this juvenile characteristic of this more upright pelvis. Thinner males and females have this big development in the pelvis during puberty. So this is pretty interesting. And when you put them side by side, it's very, very apparent which is male and which is female. And this is the only true, in a court of law, the pelvis would be the only true accepted, identification of male or female.